Okay, so welcome everybody to the repeat webinar on looking at PD in AKI. So welcome back for a second time, and we had so many questions the first time that we are doing this again. So we're going to start with, I'm going to give an overview for 10 minutes, and then we'll have some clinical follow-ups. And then Simon Davis will follow on with facilitated discussion. So summarizing what we talked about in the first webinar, we'll go through the scale of the problem, the ISPD guideline for PD in acute kidney injury, the clinical experience, and then the ASN paper, which has been published since the last webinar. So both in the UK, so this is the report from the ICU group, which shows that about 20% of people in ITUs develop acute kidney injury requiring renal replacement therapy. And similar data from the US. This paper was published in JAMA from New York, which showed that there were commented that 320 patients were ventilated and 25% of those required kidney replacement therapy. So such a heavy requirement for kidney replacement therapy has overstretched the resources available for CRRT, and we therefore have to think about the role of PD. So what is the role of PD for acute kidney injury? There are many advantages. It's relatively cheap with a minimal infrastructure required or training. It provides cardiovascular stability. You don't need vascular access. You don't need anticoagulation. And this is a big problem with the CRRT with COVID-related AKI. You don't get disequilibrium, and you may get more rapid recovery of the renal function. The disadvantages are that you need to get peritoneal access, and that can be problematic. You can get increased intraperitoneal pressure, which will have effects on pulmonary mechanics. You can get mechanical problems such as catheter drainage or leaks, and there may well be an inability to dial in ultrafiltration volume. And ITU personnel like to be able to remove, say, 200 mils an hour or 300 mils an hour, and you can't do that with PD. There are already existing guidelines for PD and acute injury that was published in 2014 and are available on the ISPD website. And these are currently being updated and out for review. In this updated guideline, there's a table which summarizes all the studies that have been done comparing outcomes on CRT or daily hemodialysis as against PD. And these are summarized in this table. The first four show that there's equivalent mortality in all these studies. And the most recent study from Saudi Arabia suggests that there in fact may be a lower mortality in the PD group compared to the group that was on CVVHD. We also heard in the last seminar reports from both the UK and the US of units that were already doing PD for acute kidney injury related to it. The King's College group have the biggest experience. They've been, at that point, they've been doing it for 3 or 4 weeks. They had inserted 27 percutaneous catheters successfully and held in 5 patients. They had had no sort of bowel injury, no leaks or exit site infections or peritonitis or catheter migration. As of the date of the last seminar, there had been 3 deaths, 7 people had recovered, 3 had recovering renal function, 14 remained on PD, and there were 5 failures who had to transfer to filtration or hemodialysis. The prescription that they used is outlined here, but as with all the suggested prescriptions, they are very they're all based on APD, starting with 12 to 18 hours a day, starting with low volumes and rapid cycles to get good clearance, and aiming for some ultrafiltration using 2.27% dextrose, gradually increasing the fill volumes and lengthening the cycles, adjusting the dextrose concentration for ultrafiltration requirements. And then after a few days, once the patient is more stable, you can start using icodextrin for the final fill. We also heard from New Orleans, and again, they had started thinking about using PD for COVID-related AKI, and went through the different ways of inserting the catheter, selecting the patients to avoid people who needed proning, avoiding people who are really catabolic with severe hyperkalemia or volume overload, or people with abdominal surgery. Their outcomes were similar. They had 18 patients so far, 3 had died, 2 had been discharged to outpatient PD, 1 had recovered remission, and they commented it must be only a US problem, and that is who's going to pay for the PD once somebody transitions off ITU to being an outpatient. Since the last webinar, the ASN has published a guideline or a summary paper in Kidney 360, and Jeff Pearl and Fred Finkelstein, who are authors of this, are going to be on the panel. I don't expect anybody to read this, but in that paper there was a very useful diagram with a sample protocol which goes through catheter placement, APD, manual exchange, prescriptions, how to monitor the patients, and thinking about what to do if any complications. So what we're going to do now is hear from Hugh Cairns from King's with an update of the clinical situation there. Over to you, Hugh.
Thank you, Edwina. There we go. So just a quick update on where we are. This is data as of sort of yesterday or today. So in total, so Edwina said we'd put in 27 catheters. We've now put in 32 catheters in total. They're all put in under local anesthetic. Whoops. That's fine. Sorry about that. The walls. We've put in 32 catheters in total. We attempted in 39 patients, so we failed in 7. In 5 of those, it was largely due to obesity. We've relaxed our criteria because so many of these patients have obesity. And in 2 of the patients, so the other 2 of the 7, we just couldn't advance the wire, possibly because of momentum. On 1 occasion, we put the needle into the bowel and aspirated air, but the patient remained fine and there were no sequelae. As Edwina said, we really have had very few mechanical complications. In 1 patient, we had a scrotal leak after about 3 or 4 days. So we stopped PD, switched the patient to CVVH, and I removed the catheter the other day, and the patient remains on filtration. We've not had any episodes of peritonitis or exit site infections, and what surprised me is very few problems with drainage. I mentioned 2 weeks ago we had 1 patient with a profound ileus. That then resolved. The patient continued on PD, and he's since recovered renal function, has a creatinine of 70. So just in terms of our outcomes, so we got some information from ITU. So at peak, RRT in ITU from COVID, which was Friday before last, in the King's ITU, there were 47 patients with COVID requiring RRT, and of those, 14 were on CVVH. 13 were on intermittent hemodialysis, which we've now set up in our ITU, and 20 of those were on PD. So clearly the Trust's ITU would not have been able to manage without peritoneal dialysis. So of the 32 patients, 9 of those have so far died, so that's 28%. They all died of COVID, none died of any PD-related problems. 14 of the 32 patients have recovered renal function and have come off dialysis. That's their current creatinine range from 53 to 321, but the patient with a creatinine of 321, it is still on the way down. Of the remaining 9 patients, I think 5 are still on PD, 4 are currently on CVVH or on intermittent hemodialysis. One of those is a scrotal leak. 2 of them have gone back to continuous renal replacement therapy because of ITU prejudices, I suppose, or preferences, and 1 was because the PD wasn't really working well enough. So our conclusions are that acute PD is effective on ITU for COVID.
Thank you, Hugh. Should we now move on to Miran's report?
Thank you, Hugh, and thank you, Simon, for having me back again to review what we've experienced here in New Orleans. This was obviously new for us to do acute PD, and so we've learned a lot over the last few weeks. And fortunately, in New Orleans, we've started to see the numbers come down drastically, and so right now things have started to stabilize significantly. I was able to get data on 13 of the patients that had acute PD across 3 hospitals in our region. There are different nephrologists actually doing this at this point. All of the catheters were replaced by general surgery, many of them at the bedside in the ICU. There have been 2 patients so far transferred to the outpatient PD facility, and one of them is currently in training, and one of them has transitioned to in-center hemo just due to a home situation. We've had 2 patients with mechanical failures that have subsequently transitioned to in-center HD. A lot of this is thought that in one of those, the surgeon experience with placement of catheters is not as great. And so I think this is something to think about depending on your hospital. We've also had 1 patient who converted to in-center, or not in-center, but HD in the hospital now. And that was due to suboptimal clearance. This patient, despite using pretty high volumes of 2.5 liter exchanges, rapid volumes, we still couldn't get the BUN much below 90. And with the critical care team, we decided to switch the patient to intermittent hemo. We've had 7 who've passed away, and we've had 1 patient who actually recovered renal function prior to discharge. So we've had a lot of learnings from this experience thus far. We haven't had any new ones in the last 2 weeks or so at this point, as things have stabilized, like I mentioned. The biggest challenge, of course, is figuring out what to do with these acute PD patients as they transition because of the United States experience with acute PD as the outpatient. We actually have a webinar discussing this through the ASN tomorrow, so I think this will have some interesting information for those from the United States. And with that, I'm going to pass it back to Simon. Thank you very much.
Many thanks, Miran. So I now take control. So we're now going to move on to the question and discussion section of the meeting. Just before I start introducing the panel, can I just please remind you to ask questions? There should be a system whereby you can write questions, and I can track those as they come in. And at the moment, I'm not sure that I can see any or many coming through. So perhaps if you could start thinking about that, asking questions. Hi, Steve. I've seen some coming through now. and I will keep an eye on those and put them to the panel as we go through our structured discussion. So I'm now going to introduce the team to you. My name is Simon Davis. I'm obviously the chair of this discussion panel, working at Keele in the UK. You've already heard from Hugh Cairns, who leads the King's Group on PD, and he's joined on the panel by Elaine Bowes, his senior clinical nurse specialist. Elaine's perhaps a little unusual in that she's also very experienced in placing catheters both for chronic and acute patients. So she's also got a lot of experience in that area. We've already heard from Miran around the New Orleans experience. I'm pleased to have with us today Professor Laden Goranstane from Albert Einstein. I'm going to ask her to say a little bit about her experience in a minute, because I know they put in about 30 patients on PD for COVID. We've also got on the team Brett Cullis, who spoke at the last webinar. He's the author of the last AKI guidelines for ISPD and will be contributing with Jeffrey Pearl from Toronto and Frederick Finkelstein from Yale in writing the next iteration of the guidelines as we go forward. So in terms of the discussion itself, I have put together a bit of a framework for this discussion today, just to make sure that we really cover all the issues that we want to get through. And so we will talk a little bit about the framework, so the role for PD. We'll discuss staffing issues, which I think are a major issue in this area. And then we'll move on to the more practical stuff around catheter insertion, dialysis prescription, what we mean by dialysis prescription in this context, fluid management, and then we'll discuss troubleshooting issues. And then finally, I hope to finish off with some lessons we've learned from this whole experience and how they might be applicable to the wider use of AKI, for PD for AKI after COVID. So let's start off with that first question. Laden, I was going to go to you first, if I may, partly to give you a chance to speak. But the questions I want us to deal with first of all really is, what is the role of PD in this situation? I'm thinking particularly not just which patients is this suitable for, but also what is the strategy that you're using it for here within your intensive care setting. But perhaps as you answer this question, Laden, you could just say a little bit about what you've been doing, the numbers, so you give us an opportunity to hear what you've been doing. Thanks.
Thank you so much for having me, Simon, and the group. Yes, so as the audience is aware, New York got hit hard with COVID. There was quite a surge, and we became desperate right within the second week of March because our dialysis nurses were falling ill, and our hospital all of a sudden had 6-7 makeshift ICUs where none existed before. So we had a huge increase in the number of patients we were tending to, and we had a lack of resources, personnel, as well as dialysis resources. A lot of these ICUs, the nurses were not trained to deliver CRRT. There were no water hookups, so dialysis was not an option. So we kind of quickly thought on our feet and came up with the solution of acute PD. This is a hospital that had done some manual PD on and off. We don't have a large PD outpatient population, so this was kind of running by the skin of our teeth a little bit, but we went ahead and, out of really desperation is the honest answer, formed a task force of nephrologists. And we started with the manual PD supplies that we had over that first week or so. And we went around the different ICUs. There was 3 or 4 of us, and we did the PD exchanges. And at the same time, we showed the nurses how to do them. They were extremely eager. I couldn't be more proud to be part of this institution. Honestly, we all came together, and we also gave them laminated cards on step-by-step procedures on manual PD. After about a week, we were able to get 15 cyclers, and we started doing the cyclers, setting up the cyclers, we being the nephrologists on the task force. And at this point, we were joined by a nurse practitioner and some other trainees who were helping out manpower-wise. So we went around and used the ISPD AKI guidelines, and we went ahead and programmed the cyclers for the patients and came later and took the patients off. So that's a very brief description. We started 33 patients on peritoneal dialysis. The catheters were put in by our surgeons, who are quite adept at doing this for us. And the surgeons put them in laparoscopically bedside, because all of our operating rooms are closed. And these were the ICU patients who were intubated, got them placed bedside laparoscopically. The floor patients that were not intubated and were able to be transported had their peritoneal dialysis catheters placed by our interventional radiology department, actually, who really stepped up in a big way and did it fluoroscopically. And actually, I saw on one of Edwina's slides, there was Dr. Jacob Cinnamon was the head of our interventional radiology department, and he's the one that kind of took it upon himself to do this. We were successful with all of the catheter placements, and there were no issues with the placements themselves, but we had some infections later on in the course that I can get into if you would like. I'll stop there.
That's great. That's a very nice description of what you've been doing. I'll finish with you. Give you one more question, Lad, and then I'm going to get around to the rest of the group. One more question was: were there any patients in whom you really didn't consider the PD? Was it something that you didn't want to do in some individuals?
Well, to answer that question, initially we were desperate, and so that was not a consideration. But later on, as more services became available, by that I mean as more nurses came back and as we got more CRRT machines, then we became a little more selective, and it became obvious to us that these patients with the cytokine storm who have multi-organ failure, PD, or the PD that we put them on, was just not controlling their uremia or their electrolytes very well. And so we had to supplement with hemodialytic and CRRT modalities. So if I had to, do it again, hindsight 2020, if I had resources available, I would say that acute PD was really a good therapy choice for those patients who were on the floors in the wards. They did quite well with it. We had a number of recoveries, but probably not the best option for those patients who are hypercatabolic with the cytokine storm. If anything, you could use it on the ward patients to kind of then shift the other resources to the sicker patients in the ICU, is my brief conclusion based on my anecdotal experience.
Thank you. So I'd like to get to the other two who've been doing this most. First of all, to Miran, can you say a little bit about that too? Does this reflect your experience? Was this the sort of strategy you were using?
Yes, I think we were very similar in that quickly we realized our services were inundated. We just did not have the capacity with the CRT machines, the nursing ratios. Our acute hemo nurses were working 18 hours a day and just impossible to keep up with the demand. And so out of necessity, we decided, why not try acute PD? We were already doing urgent start PD. We have a pretty robust home program at LSU. And so it just seemed like a natural trial for us to do this using the ISPD guideline. Now, we did think about which patients may or may not be the best candidates. Specifically, we looked at the patients who required proning, and so we left those patients specifically out, knowing that we were going to have some problems with the timing. But patients who are very hyperkalemic or who had 20, 30 liters of fluid or something that we needed to take off, we kept them off. But otherwise, whether they be on the ICU, but particularly the ones on the floor, as LaDon mentioned, we think that those patients on the floor had particular benefit from trying this modality out, and we were able to dialyze them, for example, 12 hours overnight or 12 hours during the day. And so that's really the process used, and I think it was successful, and in hindsight, it was well worth the effort, for sure. The biggest challenge, as I mentioned, is what happens to that patient once they are ready to be discharged, as we don't have a game plan for many of those here. And I think that if we're going to move forward, that's going to be a question that'll need to be answered in the United States.
And did you ever get a situation where you were transferring patients from hemo to PD?
Yes, actually, not so much from the hemo specifically, but it was particularly from CRRT. We were having so many issues with clotting of the filters that some patients, we just could not maintain them even on prolonged intermittent renal replacement therapy, 8-10 hours, despite heparinization, they still kept clotting the filters. And those patients were actually turned out to be great candidates for PD. We would put heparin in the bags and they ran beautifully. We found that the catheters worked really, really well, surprisingly.
That's very interesting. Hugh, just you want to pick up on any of those points and in terms of the strategy and who benefit? You need to put your microphone on. We can't hear you. Okay, I can't. Can anyone else hear Hugh? We disappeared altogether. Okay, Brett, can I pick you in while we're waiting for Hugh to sort himself out? Can you just comment on these experiences and how they fit with your experiences of doing PD on the intensive care?
I think they fit very well with what we've seen. We obviously haven't had many COVID patients. Fortunately, in South Africa, we're still early days, but we've been doing acute PD for a number of years, and it does the thing about acute PD that I always find surprising. I don't know whether the other groups have found this. You're almost surprised at how well it works. You kind of you do it and you kind of think, is it really going to work? And then it works so well. You're very surprised by it because we think that it's not a good form of treatment. But if you look at all of those studies that Edwina showed you earlier, you know, those studies from Brazil and Saudi Arabia, and from Thailand, all have very sick patients. They're all, so 70% of patients ventilated. So in the ill patients, I think it works very well. I agree with Ladan's comment. You know, the cytokine storm patient, the patient who's very hypercatabolic, high lactates, those patients, we struggle a little bit with those. But the other part of it is that we worry because we see a creatinine sitting at 600-700, and we think, well, we're not getting enough dialysis because our CVVH machine gets the creatinine down to 120, 130. But actually, the patients still do just as well from a survival point of view. You know, those studies from Brazil and Thailand show that the patients do just as well, even though they don't get their creatinines down that low. So, yeah, I think the really hypercatabolic patients, I would be nervous on, and if you've got an alternative strategy, maybe those patients should be getting CVVHD. For the other patients, I think PD is a good option.
Great, I'm going to get back to Hugh now because I think we could hear you earlier. I can hear you now.
Excellent. Sorry about that. So again, at King's, this was responding to an emergency, initially with CVVH machines and then ultimately with the consumables and things. I agree with Brett's comment about the biochemistry. One of the issues we've really had is getting the ITU staff to understand that on filtration, they get a patient down to creatinine of 100 or 150 and a urea into the teens, if not below that. But the biochemistry we can produce with PD is not that good, but nevertheless, the patients do very well. In terms of patient selection, we were really driven by the ITU staff and identifying people in whom we could put local anesthetic PD catheters in, but we were really, at the end, willing to consider anybody because the pressures were so great on the ITU.
Okay, I think we've heard quite a bit about strategy. I will give the others opportunities to step in, but I'm going to move the discussion on now to staffing issues. Edwina, I'm going to start with you here, if I may. Can you hear me?
I can hear you.
Because I know that you had a go at this and there was some quite difficult staffing issues. Perhaps you could say what your problems were, and then we can go back to the rest of the group and see what sort of solutions were put in place.
Well, our ITU has never ever done PD. So it was entirely dependent on support from the PD nurses, who equally have been PD nurses for a very long time and are not used to working at weekends, out of hours, etc. And that caused quite a bit of tension. Also, the PD unit is phenomenally busy at the moment because PD has suddenly become the chosen modality for new patients, because it has taken COVID to persuade my colleagues, or many of my colleagues, that dialysis at home has many advantages to dialysis in hospital and then getting COVID. So the PD nurses were very busy with new patients and were very stressed. We also had problems with the ITU staff who equally had struggled with not being able to diagnose infiltration, problems with creatinines that didn't fall and ureas didn't fall. So we successfully did PD on 2 patients. One recovered renal function quite within a few days, and the other one has now been converted to CVHD. It is fair to say that we started at the time when numbers in ITU were beginning to fall, and also supplies for CRT started increasing. So the staffing issues, plus the fact that there was no perceived need for PD, but there was now adequate CRT, meant that we've now stopped doing it.
So, Elaine, can you hear me?
I can indeed.
So just tell us a little bit about how you solved these staffing problems at King's, because they're clearly is a big issue.
So we were very lucky in that we contacted some of our ex-staff who were still working within the trust in different areas. And I guess I'm lucky enough that a lot of nurses have come through the team and been promoted or moved on to other areas to do different things, and without exception, all of them wanted to come back to the team and help us with what we required in ITU. And so it did mean that literally overnight we were able to get a team together to be able to support the ITU team. We have an on-call system at night, so we're working basically 7 in the morning till 8 at night through ITU in order to get people on, take them off, problem solve, etc. And then at night, we had an on-call system whereby myself or one of my colleagues would answer questions through the night and problem solve over the phone. And if that wasn't successful, we would then get a nurse from the ward, the renal ward, to go to the ITU with an understanding of what the issue was before they went. And I have to say, the ward team really stepped up as well to assist us with that. I have to say we used a lot of picture guides, templates for what was required. I think my relearning in this is that we should have done maybe more training of the actual intensivists and get them not to be so afraid of them. Because a very simple thing to page down to find out how much the current UF was something that they found very frustrating, not knowing the current UF. But of course, all you need to do is page down a couple of times on the machine and you see what the current UF is, the running UF. And I think we've had a meeting with the intensivists today, and their learning from this is that patients will do well and will recover function despite having high ureas and high creatinines, that often some fluid or water down the NG tube to actually just hydrate the patient a little bit more. It does a lot towards the recovery of our AKI patients. And that now they have a little bit more faith in the system, that they would want to refer patients to us in the future, even outside of a COVID event, which was nice to hear today. So I do think, I mean, obviously this is a big commitment. I think we're lucky enough that our team were willing to do so. Certainly, yes, weekends and evening and nighttime work have just become the mainstream, but we were doing that anyway in other areas. So for us as a PD team, it was quite nice to do it in our own area. So that's our experience of it.
And Laden, did you teach the staff to do PD on the ITUs? Did you do some training? Do I understand?
Yeah, so our main ICUs, a lot of the nurses already knew how to do it, and actually they stepped up and taught each other. The problematic areas for us were those new makeshift ICUs that were basically staffed by, you know, home care nurses or outpatient nurses who had no experience with ICU patients. So for the first, you know, week or so, it was very much deer in headlights. And so that's where we really stepped in and did those exchanges. And then after a few days, you know, one of them would come forward as kind of the super user and get trained by us. And, you know, anyone with PD experience who actually chose to round with us. And once they got trained on the cycler, you know, I always told them it's not rocket science. They were able to kind of set it up themselves with some manual guides that we provided by the suppliers and the companies. And so it became easier after that first week in these makeshift ICUs. On the wards and the ICUs where the staff had some training, I feel like they helped each other, and we just kind of provided oversight as the PD nephrology team. We went around and provided oversight, but it worked surprisingly well, surprisingly well.
And Miran, my recollection is that you had to set this up in 3 different centres in New Orleans. And did you have to teach ITU staff as well, and were they receptive to that?
So interesting, our scenario is a little bit different. So we did this in 3 different hospitals around the city. The dialysis services are actually provided by DaVita Acutes, which is our inpatient dialysis provider at all of these hospitals. And so the dialysis nurses already were familiar with PD, and they were the ones doing it. And then we were lucky enough in that they were able to bring in nurses from other areas to help with the surge that we saw in New Orleans. So we did get some additional nursing help. If anything, I think a lot of the education came amongst ourselves as nephrologists on how to do this. So we held conference calls and had group me text messages, and that's how we learned how to troubleshoot it together.
So I've got a lot of little practical questions to throw out there now, which are coming through from the group, from the participants. So perhaps you could I'm just going to reel off a few of those questions, and perhaps I could then ask you to pitch in with some of the answers. So I think mostly been putting in Tenkoff catheters rather than hard catheters, but it perhaps makes a comment about that. Who's putting them in? What technique are you using to put them in? Are you doing the PD prone in anybody? Was there any concern about infection risk? There's just a few practical issues there. Hugh, do you want to start those questions off just to sort of get things moving on that? And then.
Yeah. Okay. So we, in our unit, we have a long history of putting catheters in under local anesthetic by nephrologists, or in Elaine's case, nurse. And therefore, that's what we've used on ITU. We have involved a radiologist, partly as a sort of point of principle, and we've taught him how to do it, and he's now doing catheters on his own under ultrasound control, although not with fluoroscopy. We do have a surgeon who puts in laparoscopic catheters, but we've not chosen to do that on ITU, although we could do so. We always use Tenkoff catheters, not hard catheters, and I can't really see why we would want to put hard catheters in these patients. We've been keen to try PD in a prone patient, but in fact, coincidentally, although a number of our patients have been prone, that tended to be before we put the PD catheter in. I think only one has been prone, and we didn't get to try PD then. But my understanding is that other people who've tried it, it does seem to work. So our view would be, in terms of the catheter to use, would be to use a Tenkov catheter. Which method you use to insert it really depends on what you're used to in your hospital. If it's local anesthetic, that's great. If it's by surgeons, then involve the surgeons, for example, as they've done in New York and in New Orleans.
And have you had any problems with leaks?
No leaks at all. I mean, we had the scrotal leak, but that's different. But no patients leaked. We've had no exit site infections and no episodes of peritonitis. In a sense, it's not surprising we've not seen leaks, as these in our experience, when you use catheters acutely, that what gives rise to a leak is a patient getting up and mobilizing when they have fluid in their abdomen. And of course, all of our patients have been on ITU, and therefore mobilization has not been a problem. Be interesting to see if they leaked when prone. The one patient who was prone with a catheter in didn't leak, but we didn't do PD whilst they were prone. Yeah. Elaine, any comments on that?
Yes, we just haven't had to prone any of the patients who were put on PD. I think often because they quickly turned a corner once they were on the therapy. I guess in relation to the catheter insertion, it was actually really useful for me to work with the interventional radiologist. And certainly there were some bigger patients that without, not that the ultrasound made it made it safer in that I knew that I was going to have to bury the needle, and you have a lot more confidence in burying the needle when you have an idea of how far the peritoneum is. It was less useful to actually do at the time, just because the patients were so large that it was hard to see a clear picture of the progression of the needle into the peritoneum. But sometimes it was very useful. And I think in relation to moving forward, I think our interventional radiologist is keen to keep putting in catheters, maybe even under fluoroscopy and IR. So again, this might be a boon for our service in the future.
Can I ask anyone on the group whether once you started people on a PD, you had a problem with intraperitoneal pressures affecting ventilation? So were there difficulties in getting people ventilated because of the PD fluid in situ? No. So that's a fairly, because that's a common concern I think that people have around doing PD on the ITU, but actually this is not an issue really.
I mean, I will add that we were using, smaller volumes. We were using 1.5 liters pretty consistently, depending on the prescription, but maybe that has something to do with it, but we never had a problem.
Yeah, we used large volumes in larger patients. And again, it wasn't a problem at all.
So let's just talk a little bit about the amount of dialysis you were giving them, and how many liters you're getting through. Did you feel that you couldn't? You've already mentioned that the cytokine storm patients who were difficult to fully dialyze. What was the criteria upon which you stopped PD or topped up with some CVH? Was it the biochemistry? Was it other factors that led to those decisions? Miran, do you want to start with that discussion?
Sure. Generally, we were using, so we started everybody with a 1 liter exchange volume and then rapidly went up from there. Most patients probably ended up around 1.5, although we did, like I said, after about a week, we had one patient on 2.5 liters, and still despite that, they were so hypercatabolic, we had trouble clearing them. So in general, our total volumes were somewhere between 18 and 25 liters a day, with that one gentleman actually upwards of almost 34, 35 liters. The only patient that we converted for clearance was just him, and his BUN really never got below 90. And so, what Brett said, maybe it really wasn't a problem, but I think the concern, especially from the critical care team, was that, could this be contributing to some of the mental status and respiratory issues that the patient had experienced? And so we switched him over. But as far as the other patients go, there was never a clearance issue for why we converted them over. rather it was a mechanical failure for a couple of the patients. And then the rest of them did fine.
Brett, do you want to comment on that in terms of your wider experience?
Yeah, so I mean, we will start with 2 liters as a full volume. In most of our patients, if they're small patients, we'll go to 1.5 liters. So we tend to start quite high, but we haven't had problems with that. We don't very often see a leak either. And I think leaks they're patient dependent or person dependent. I don't think you can predict it on volume, and there's data to support that. So we tend to use about a 2-liter start fill for most of our patients, and that goes with what we put forward in the ISPD guidelines, that patients who are between 60 and 80 kilos, you would start with a 2-liter full volume and you'd do a 2-hourly exchange in those patients. If they're less than 60 kilos, then we'd use 1.5 liters. And more than 80, we'd do more rapid exchanges, but with 2 liters. The 1.5 liters is what they used in Thailand, showing very good outcomes using 1.5 liters, but their patients averaged about 60 kilos in weight, so they were quite a lot smaller patients. With that, you get very good outcomes, you get good survival, and I would recommend using the slightly bigger volumes, and we don't see the problems with the ventilation with that. I think I said it last time, fluid balance is the key, and that's my biggest problem in ICU, is that patients get fluid overloaded too easily, and we've got to keep them in a neutral fluid balance. So once they've been adequately resuscitated, keep them in a neutral fluid balance, and so use higher volume or higher concentration glucose to achieve that ultrafiltration. I don't think we must be scared of the high concentration glucose bags. I think it's helpful, and it will help with convection as well, which may have a benefit in terms of larger molecule clearance. Whether or not that's important, we don't know.
So if I could just ask around that, because there have been a few questions around this, can you tell us what your initial dialysis prescription would be from the point of view of ultrafiltration? So you going in straight on with 2.5% glucose or stronger, or?
It depends on the patient. So
obviously,
I mean,
something.
I mean, we're with our acute patients, some of them they've got AKI because they're dehydrated, so we're going in with a 1.5. I think if you've got a general ICU patient, generally 2.5 is adequate. And obviously, if you're dialyzing them, if they're overloaded, we would go into the 4.25 straight away. And then we just adjust according to how much unit we're getting. And occasionally we alternate in bags. It's very much patient dependent.
So
Simon,
yes.
Fred, can I just point out one thing, which is that in the Brazilian studies where they placed PD catheters in the intensive care unit, they were able to get weekly KTOVs that were over 4, which would be equivalent to what you get with a daily hemodialysis treatment. So you can get actually quite high clearances doing PD, again, using a cycler with hourly exchanges. Again, if you're focusing on small solute removal and you're worried about urea levels, clearances can actually be driven up quite high with PD.
Thanks, Fred. So I've had a bunch of questions around infection risk, which I'm going to probably try and answer myself, but I'll then throw it out to the group to add anything to it. But one or two people are asking about the infection risk here. The answer to that is that you can get this virus in PD fluid. There has been at least one case report growing it from PD fluid in a bad case of COVID. But actually, the majority of where it's been looked at actually has been negative. But of course, if you get it in one, then it shows by principle it can happen. So therefore, you do have to treat this fluid as if it's infected. So you have to remove it in the usual ways of infected materials, and of course, destroy the plastics associated with it. Has anyone in the group felt that this was a problem on their units, infection control or management? Did this put your staff off? Were there any issues around that?
I think our surgeons, this is Ladan, our surgeons were concerned. And so one of our infectious diseases specialists started collecting PD samples, which she has a lab identified in New York State to test for viral load in those PD fluids. We don't have the results yet, but that was a concern.
Yeah, we've tested as well, and we don't yet have the results. But it's certainly, I wouldn't, Elaine, say that that was a source of anxiety for the nursing staff. I think the nursing staff initially were very scared going on to ITU, but that was just going on to ITU rather than dealing with the PD fluid.
I think the bonus of being in PPE is you are particularly protected in ITU at the moment. And I guess that's the other bonus for infection. And I wonder if that's had a lot to do with the fact that we've had no peritonitis and or exit site infection, simply because everybody is gloved up and gowned up and washing hands and changing gloves. And that's why it just hasn't been a particular issue. Getting rid of the fluid, I would say the volume of the fluid was more the issue of getting rid of the fluid than the actual process by which we did it. And I have to say, our ITUs actually in the end provided runners to assist us with actually rid of that fluid, because if you can imagine, you've got 40 litres of fluid going through a patient and then you're UFing up to 5 litres. There's actually quite a lot to get rid of through in the sluice area. But generally, it hasn't really been a particular issue. We have done it in the same way that we do it elsewhere, with the exception that everybody is in full PPE because you are within the ITU setting.
So we've got about 6 minutes to go, and I've promised the team that we will finish on time today. We went over by half an hour last time. So I want to wrap up the last section and try and give everyone a chance to speak, and I'm aware that everyone has. But what I want to focus now on what are the lessons that we've learned from this, which are applicable for future growth of use of PD for AKI. A number of questions have come in around that. For example, there's questions around catheter insertion, ultrasound, nurses doing it rather than just docs. There's a number of issues around things like recovery of residual kidney function. How's the best way to optimize that, and transitioning people from the ITU into longer term recovery. So if you could think about those sorts of issues. Jeff, I haven't had a chance to speak to you yet, so it's your turn for a little comment. You're about to help put together the next set of guidelines. What do you think we're learning from this, which is going to help inform those?
Thanks, everybody. I think the big question, and this is something more broadly, is we certainly have realized that PD for acute kidney injury has been a therapy that's been looked at during a surge time for dialysis requirements. And I think what we need to better understand is there's a clear value that's been established, and Brett and Fred have done this work in low and middle income countries with a very well-established role for PD for acute kidney injury. Moving forward, in the absence of dialysis surge, I think we need to all ask ourselves, what do we think the future role for PD for AKI is? And have we learned anything about using it in this context that will help us better establish a role for it in the future and understand the advantages and the challenges? So I think that's one big thought, I think, moving us forward in the future. It's no doubt that, you know, from Laden's experience and others, people are putting in PD catheters with modalities that they never had imagined they would need to put in before. So I think it's important, although an operator isn't on the telecall today, the webinar today, it's really important to engage our operators. And for those of us who won't be placing the catheters ourselves, really engaging people to say we need more and multiple methods of PD access insertion for different scenarios. So I think that's an emerging and important theme here, involving and better establishment of different access pathways. And then lastly, you know, PD has been designed as a maintenance ambulatory therapy, which we're applying to the acute care setting. I think that there's a lot with the technological advances in cycler technology and infection prevention, that if PD for AKI takes off, and I hope it does, that we think about redesigning our machinery and our technology specifically in the acute setting. There's no reason in 2020 why one can't get ultrafiltration in real time delivered from a cycler as it's taking place, and to leverage a lot of the remote monitoring to help support people to deliver it in critical care. So I'd say that's sort of a third pillar in terms of a direction for the future.
Simon, can I just say?
Yes, do please, Edwina.
That from our ITU, but there were awful problems with Wi-Fi signals, so it didn't work. But what emerged, because the ITU we were using was the cardiac ITU, where the 2 PD patients happened to be, was an interest suddenly from the cardiac side about, isn't there a role for PD in people in the future with poor cardiac function, once all the dust has settled from COVID?
Brett, I'm going to come to you last because you're going to wrap up. So I'm just warning you of that. Can I just ask perhaps Hugh first, and then Miran, and then finally Larden, just to say in very brief terms what it is you think you've learned from this experience?
I think the major issue from my point of view has been communicating with the ITU staff, getting them to understand how PD works, the biochemistry, the benefits of it. And I didn't go to the ITU meeting today, but it sounds as though it went very well. And I would hope they would see a role for for PD on the ITU in selected patients. A lot of the patients I was struck, they were running very dry, and putting them on PD enabled us to probably improve their fluid state, and maybe one of the reasons why lots of our patients have recovered function. So I hope that we'll be able to do more acute PD on the ITU, but it will require a bit of a culture change for the ITU team. Yeah.
Thank you. Miran?
I think for us, big lessons learned, we have a great relationship with our critical care faculty here, and I think we realized that this could work in the ICU as well. More importantly, though, I think this could also work on the AKI patients on the floor, for example, and rather than putting in a hemodialysis catheter and discharging them with a CVC to the outpatient setting and the risks associated with that, why can't we transition some of these patients on PD, knowing that PD potentially preserves residual kidney function and may have better recovery of that kidney function to come back based on some of the studies that were already discussed. So I think for us, the next step to this would be, can we identify patients who would benefit from this, who would be successful at home and be able to go home with AKI dialyzing without getting a CVC in their neck in the future.
Larden, you want to say anything?
I think in our experience, acute PD saved lives, and that was very, very meaningful for us because these were patients that wouldn't have gotten any kind of renal replacement therapy otherwise. But as far as my personal take on what I learned, having been a medical director of a major outpatient home unit in the Bronx, I'd never actually done an exchange or set up a cycler myself because I just have such excellent outpatient nurses. So I learned how to do those things, and now I really understand the mechanics of everything.
Great. Brett, you want to finish this off?
I think there have been positives coming out of COVID, a lot of negatives, but a lot of positives as well. And for me as an acute PD enthusiast, it's been great that in high-income countries, it's actually been shown to be effective, which gives those people in the low and low middle-income countries actually a lot of support for their programs where that's the only dialysis that they have available. So that's been a great learning thing for us, and also supports our acute PD. And I think the comment by Miran and by Jeff is that and by Hugh, that this is a complementary therapy. And just like we do acute hemodialysis, we do CRRT, I think there will be a place for acute PD, and I think we've just got to find where that fits in. But certainly, I do think there is a role for acute PD. We did the guidelines in 2014, and there were a lot of questions in those guidelines where we didn't have evidence base. And following the guidelines, a number of studies were done, which then gave us answers. And in our new guidelines, we can actually come forward with a bit more evidence base for what we do. And I hope that the new guidelines that are about to be published will give us more questions, and there are a lot more questions we need to answer. And hopefully, in 5 years' time, we'll have even more evidence. And the question that we need to look at are there other modalities or other ways of getting access. I certainly think there are other designed catheters that might be. I think we need to look at middle molecule clearance, maybe not so much small solute clearance, but also just looking at outcomes, because my personal experience and the studies that have been done show that PD does appear to be as good as other modalities. And if we can get more in the way of evidence, especially if we can get a multi-center study showing that, I think that'll go a long way to pushing PD in the future.
Thanks very much, Brett. Well, we're past our hour, so I think we should stop now. There are a few unanswered questions, but I assure you that the answers to those questions are in the guidelines. So please look at those. And I think if this could be a stimulus to more research in the role of AKI and PD, then that really would be a wonderful outcome for this. And I would strongly encourage all the groups who've talked today to publish their results, and indeed others out there who might be listening in who've got some experience to publish their results, because the bigger the evidence base is, I'm sure the more we'll be able to advocate this treatment. So it just remains to me to thank everybody for being involved, and take care. Bye.
Bye.
Bye-bye, everybody.
Bye-bye.